Good afternoon, everyone. My name is Ian Chang. I'm a partner at Flair Capital Partners. Flair Capital is a dedicated healthcare VC fund that focuses on investing in innovative digital health companies. We're very excited to have you join us today for our 14th quarterly expert roundtable, Focus Factories, the Rise of Specialized Primary Care. Let me briefly set the stage for our discussion before we dive into our conversation with our esteemed speakers. In the past decade, we have rapid growth in Medicare Advantage adoption, the emergence of new public and private payers-led ACO models, the rise of advanced primary care. Yet, we're still a long way from being able to address all the unmet needs. Over the next decade, we'll see a significant shortage of PCPs due to the changing demographic, physician burnout, CMS rate reduction, and many other factors. While there are significant headwinds facing the industry, there are bright spots emerging. We have witnessed the rapid ascent of novel primary care models and the rise of focus factories. Special needs plan enrollments have surged. Nearly 7 in 10 new MA enrollees opt for special needs plans. With that said, I'm excited to be joined by a group of senior operating executives and entrepreneurs, including 2 CEOs from the Flair Capital family, who will share their perspectives on the increasing specialization of primary care. Our speakers include Benoit Bensali, co-founder and CEO at Diverge Health, Brooke Boyarsky-Pratt, founder and CEO at KnownWell, Sylvia Hastinen, co-founder and CEO at Greater Good Health, Sean Morris, board member and retired CEO at Privia Health, Dr. Richard Park, co-founder and managing partner at Ascent Partners. Dr. Park is also the founder and former CEO of CityMD and currently the CEO at Renda. We're honored to explore these questions and more with a group of leaders experienced in building tech-enabled population-specific care delivery organizations. So with that, I'll invite my partner, Michael Greeley, to the stage for a conversation with Sean Morris about scaling a tech-enabled primary care platform and his take on the opportunities for more specialized primary care. Michael, over to you.
Thank you so much, Ian. A wonderful setup, and Sean, great to see you. It's our great pleasure to have such a successful and noted entrepreneur in our category. Managed care has been obviously a very important topic. It's a controversial time in the sector, but maybe just to start, Sean, briefly introduce yourself, tell the HealthSpring story, the Privia story, if you would.
Thanks, Michael. Great to be here. I still enjoy doing this, even though I guess I'm retired. I usually start in the fact that I'm an accountant, publicly accounting way back. And the reason I do that is all the clients I had those 4 or 5 years, the majority of them were physicians. And with that being said, I was a much younger man than I am today, but I did learn to work very closely with physicians, all their organizations, medical groups, every shape and form, which actually kind of shaped the future of kind of how I saw healthcare and the things I enjoyed about it. But went from there. I ran and got with some people on the call remember PruCare. Michael, I'm sure you remember the old PruCare days and the group model HMO where the insurance company formed a group. And I was thinking about that the other day, and they didn't call it capitation, they called it a negotiated budget. But I was a CFO for a group. And gosh, that was back in the 90s. And we had over 40,000 commercial lives that we had negotiated a budget for. And then in turn, that's where I got interested in Medicare Advantage. It was called Medicare Risk at the point. And at that point in time, it was the most interesting thing to file for a plan. You basically submitted a Lotus Note spreadsheet to HICPA at the time when it had to be signed by, we actually went up to Milliman in Philadelphia. They signed it and all the assumptions, and we were a senior plan at PruCare. But I tell that story because that's where I met Herb Fritch. Herb was building IPAs all over the country, and I was really intrigued by their model and how they took risk from insurance companies. And it really, that was in the days it was called North American Medical Management, or NAM. And I went to work for Herb and moved to Chicago and started and helped start that market up. But that led to the first wave of physician management businesses back in the day, the Med Partners and all those. And we were bought by FICOR. So we all know how version 1 ended. A lot of lessons learned. We took lots of risk, and the risk side of that business was very successful. Round 2 at Herb, he formed at the time the predecessor company, the HealthSpring, and it was that the business was buying and rehabilitating broken health plans that really didn't have the right network model. In our opinion, his opinion, weren't engaging the doctors in the right way from incentives and reimbursement, and really just trying to incentivize the doctors and get them organized in a way. And we chuckle now, but then show them some form of data and really on a piece of paper of what they were, I guess, doing right, doing wrong, that type of thing.
And Sean, in the early days, was the incentives bilateral? Were there only upside to the docs, or how were you thinking about it in those early days?
Yeah, we really did. We were probably some early pioneers there. We wanted to, just like today, if you look at Privia, the end game was getting the doctors to, in an IPA model, to professional risk. We never put them at institutional risk, and but we shared institutional upside with them. That was the end game. Now, we all know, even back then, you can't just dive into that. So we always started off fee for service with some upside. We were doing quality. We called them widgets at the time. If you do this and do that, we'll give you a little bonus here and there. Really, with the end game pointed to where they were taking professional risk. And it was an IPA of every specialty. It was primary care based, but at the same, because that's where the attribution came from.
Yeah.
But we capitated multiple specialties. Herb was an actuary. We had a lot of actuaries and accountants in the company. But we sold that company, or that company actually got broken up and sold when the PBM industry faltered. Or I'm sorry, we were on HealthSpring. And we actually took HealthSpring public in 05, I believe, 06, ran it as a public company, very successfully. I forgot the number of markets. We were in 15 or so markets at the time. We sold that to Cigna.
Yeah.
And,
one of the most seminal deals of the last 2 decades.
Yeah, it was interesting. We really got into that business when nobody else wanted to be in Medicare Advantage at the time. They had Modernization Act, and people were, sounds familiar, exiting products and trying to figure it out. And CMS or time had changed the rules, and Bush brought back the Modernization Act, and we thought it was a good time to get in. So we were buying and rehabilitating assets that looked to be poor assets and putting in an engagement with the doctors. But Cigna bought that. I was there for 6 years and really got a call from Goldman, and Goldman was our banker. And I knew Privia. I knew Jeff Butler and Dave a little bit. And I really liked the foundation. I liked what they had done, and building a group without having to buy the assets, real capital light.
Yeah.
And they weren't doing a tremendous amount of risk at the time, and really thought the board was asking me, can we get there? And the technology side, they had all these doctors on the same medical platform, which to me was the most intriguing part of the whole thing. So it was in the same, each market was organized into a single medical group. So there were so many things that was intriguing that I hadn't seen anybody else doing it that way, that we thought that it could be a very successful model.
Yeah, and while you open by saying you're semi-retired, I think is what you said, you're still very active in the space. Are there forces today, as you look over the landscape, that echo what you saw over the last couple of parts of your career?
Yeah, I'd say just mostly so everybody's aware of V28 and all the changes.
Yeah, I want to go deep. I want to go deeper on V28 in a minute. But at the highest level, what are the forces that get you excited?
Yeah, I think it's what gets me excited. And anytime there's change, there's opportunity. I go back to when risk adjustment came in the mid 2000s, and everybody thought, oh my gosh, this is the death of Medicare Choice Plus, Medicare Advantage. We're not going to be able to do it. And now that led us to the most recent events, but it took 15 years to get there, and it took many paths. So, and I'm a big believer that it's a great product. Seniors love it. Gosh, my mom, she passed away now, but she was on it for years and years, loved the product. And it didn't have a premium, but had all access to great benefits and the things that could help make her life easier as an aging senior in her home. And there's just, and the benefits they in today's plans are even so much more geared toward aging at home, active seniors, wherever you are in your life, you can find a plan out there that'll fit you. And but there's changes afoot, and it's a very cyclical government business. Is not for the faint of heart. And if you're, especially if you're a single threaded kind of entity, and that's all you do, there's going to be disruption from time to time. And you're going to be, if you're a public company or if you're a private company, you're going to be explaining that to your investors and what you're going to do in the meantime. But I'm bullish on the market, and I'm bullish on anything that you can engage physicians to take better care of their patients, to be that commercial, be that Medicare, Medicaid, whatever.
Yeah, and it was surprising. Sorry, Ian's opening, he mentioned that the 7 in 10 eligible members have special needs. So as you think about the rationale about building a multi-specialty practice, talk a little bit about some of the insights or lessons learned there.
Yeah, it's I guess I've just done it for so long, but when you sit back and you look at the geography you're in, and it kind of, one of the things is, and the doctors that you recruit into your IPA, your medical group, whatever structure you're going to take on, it's what type of population are they comfortable taking care of? And because we all know some physicians are what I would not apply a great term, but a white glove type doctor group that's taking care of mostly commercial patients. Some pretty active Medicare patients probably tend to be traveling fee-for-service style in an ACO nowadays, where others are only complete opposite end of the spectrum. They're in a different part of town. Maybe they're mission-based. They are really engaged in taking kind of dual eligibles, Medicaid, Medicare, or people with less means, or maybe somebody with just Medicare Advantage, and that's all they have the ability, but they just barely qualify not to be in Medicaid. So you really build your networks or groups accordingly, and then you take, as you get to know them and as you want to move them towards risk, is what are they good at and where do they need help? And and the basics are always technology. The basics are always physician leadership and governance, and how to decipher data. And that's not the way physicians tend to be wired. And you need people and professionals that can do those things for them. And what's a fair contract and actuarial means and all those things. But usually when it comes down to care management, physicians today are much better suited to do those things than they were 5 years ago.
So can I push you to go a little deeper on one element of that, which is around the behavioral health issues? There may be several dozen startups that are doing some version of behavioral health. How do you think about their role in that model?
It's interesting. I mentioned I went to my first job out of public accounting was PruCare. That group was all primary care, different types of kind of multi-specialty within primary care, from general practice to internist to family practice and pediatrics. But we also were a behavioral health medical group. So very early in my career, maybe I'm influenced because of that, we saw the benefits in aligning within the group itself, a behavioral health. And we had everything from licensed therapists all the way up to psychiatry. We saw the benefits to the patient, but as well, because they were right there embedded with the primary care, but as well as the medical cost. You flash forward that group today, that's what people are trying to do more of. You don't have to obviously embed and employ the behavioral health. And there's many models, and we were doing it at Privet, still are, where we have behavioral health, very close relationships, sharing medical records, all those type things. And we started that, I guess, with the state of Maryland, did their coordinated primary care program. And there is just really, I think everybody on the phone would understand what we saw through COVID and the benefits of being able to get access to the right level of behavioral health professional.
And we have several hundred entrepreneurs on the call now. Any practical advice? A lot of them are trying to navigate that minefield. And how do they think about their companies working in partnership with more of the traditional PCP models?
Yeah, I'm a believer of it. It just can't be primary care. And you get kind of incentives and how you reimburse different. If you were only going to capitate or pay in advance to one of those types of groups, meaning primary care or specialist, I would actually always lean towards, I'd go to the high volume specialist that you can guarantee some volume to and predict actuarially what that should look like. Because I think over the years, you want your patients to have just immediate access, as much access to their primary care, and you want to incentivize that patient to have a great relationship with them. And you don't want to ever disincentivize it. Not that some doctors would be disincentivized to see their patients capitated, but you want to remove any barrier. It is the lowest cost. And I'm just a huge believer, just because I've seen it over the years. If you have a great relationship, regardless of your age, with a primary care physician or a primary care professional, and they have access to the right specialists in a reasonable time frame, you're going to get great care. And the behavioral health is just, gosh, it's even more important. Look what the payers, it was just, I look back 20 years ago and all the payers they sold off all that and they were contracting. And what a nightmare that was, trying to coordinate that because it wasn't in the same year and so forth. But I hope that answered.
You touched on V28. Is there a set of headwinds or what would be your advice as to how to best navigate the next 2 years as that kind of unfolds?
I don't think any of us know, probably even CMS, what the final impacts of all that will be. It's drastic. Anybody we know that's taking risk and our full risk in Medicare Advantage, the MCOs, the downstream enablers, all that we're seeing daily about the impact of that. So I have a model that is flexible, that you can, and when you're contracting with your payers, you be logical about that and have great relationships with them. If you can, when there's if you feel like you need it in your contract, or if you get it in the contract, if there's an actuarial change of whatever in a contract, you can come back to the table. They're never going to give you a rate of what it should be, but at least you have the ability to come back and speak on what's occurred and what a fair contracted rate should be in the meantime. So, because you hate to say it, but it all gets back to that at some point when especially if you're taking kind of full risk. And I have various flexibilities with your model to do, because there's areas of the country and groups we all know that will probably never get to full.
And your sense is the market will tolerate that flexibility?
Yeah, obviously within Apridia, we have various different versions of risk, from fee for service with upside all the way to the more of a kind of our version, I guess, previous version of full risk. So the market tolerates. Can you show, and always, you never rely on the payer's data. That's not their strength. So have your own shop, or at least have the ability to generate that data, be diligent about it, and go to that payer. That's how we did it for years at previous one, saying, hey, this is how we're doing. Let's sit down and talk about what a reasonable contract looks like. And I think we had a lot of people there that was in the payer business, so they understand the financials of a payer. I guess it's really gets down to negotiating what each party think is fair. And we always wanted to bring the doctors into that, and they had upside and downside, and making sure those incentives were aligned as best we can make them.
Yeah, a through line for all of this, and we were talking about it last week, and as health tech investors, we think deeply about this. What are you most excited about, just in the last few minutes, from a technology standpoint? What do you see coming? Like, where do you see the impact of that playing out over the next, say, 5 years?
Goodness gracious, I can't imagine where we'll be in 5 years. I just look back over my career, and when you and I talked a while back, I jokingly said, I remember when electronic medical records, where nobody had them and people were putting them in. And
you mentioned Lotus Notes. There are probably a lot of people.
So it's been a long time. But one thing was we had Dragon voice recognition back then. And I remember sitting through demos, and it did not work at all. It was horrible. But so think how long that has taken to just voice recognition, and how good it is now. And the speed of innovation is so much faster than it used to.
What do you think the big unlock is? What are you most excited about?
I think probably in the next 2 to 3 years, it's more the administrative side of medicine, and what can we do to remove that burden off of caregivers, to where, because they don't want any of it. They don't like it. They never have. They've tolerated it because they had to be paid and they had to get paid. They had to do it. But I think they call it AI, call it whatever you want. There's so many worthless, trivial things happening on the administrative side of healthcare that if we can, we'll never alleviate them, but if we can minimize that and using whatever type of technology, I think that is where the focus will be. I'm not sure we're ready in 24 to 36 months and I think Watson and some of that other stuff has proven it. I think you can get medical advice, and I'm not even sure when this stuff really gets rolling, how different states and how we license doctors and nurse practitioners, how all that's going to play out. That's going to be probably.
Let me ask you a provocative final question. Healthcare spend is, pick a number, 18-19% of GDP. What will the impact of technology be in 5 or 10 years from now? Will that be 16%? Will it be 22%? Like, where are we going with technology?
It's such a huge part of our economy, and there's so many jobs wrapped up in it. Can entrepreneurs on the phone, can they remove some of that? Is it 2%, 5%? I don't know the number, but then take a portion of that and because you mentioned dual eligibles, that population and the frail and elderly, that is where the big premiums are. And so with a big premium, there's more margin, should be, for an entrepreneur. How can you repurpose some of that savings to that face-to-face care and take better care of those people and reduce medical costs and have them have a better experience? Because if they don't have an experience and that it's trusting and they feel like they're elderly, frail, or just really sick, it's not like they're going to improve. But if they can maintain the basic things they like to do in life for a period of time, that's really important. So how can we reinvest some of these dollars? And let's face it, maybe there's some margin in there too for the new companies and for existing. So that's what's exciting to me. And I think we're going to see a lot of that.
Great. Terrific. And we're getting the hook, Sean. I can't thank you enough. That was a great way to end. In 5 years from now, when we do this again, we'll see if your prognosis came true.
We will see.
All right. Hey, thank you, my friend. Great to see you.
See you, Mike.
I hand it off to my colleague, Tara Sullivan, for a terrific conversation. Tara?
Great. Thanks, Michael. Hi, everyone. I'm Tara Sullivan. I'm a member of the investment team at Flare Capital. We're going to jump straight into the next panel here, and we have 3 amazing entrepreneurs coming to the stage. Brooke, Benoit, Sylvia, welcome. And each of the companies that you're building are really great examples of today's roundtable topic around focus factories and primary care. You're scaling novel care models that are really purpose-built for specific primary care populations. So I want to turn it straight over to you and ask you to introduce yourselves to our audience. Please spend just 1 to 2 minutes. Please touch on both your background and the company that you're building. Brooke, I will turn it over to you and Known Well first.
Great. Thanks so much for Flare and the team for having us. I'm Brooke Boyarsky-Pratt, the CEO and co-founder of Known Well. I have a traditional business background of Penn and Harvard Business School, McKinsey, and was ultimately the COO of a Berkshire Hathaway-owned company. None of that was healthcare. What brought me to Known was my experiences as a patient with obesity navigating the healthcare system. So simply put it, Known Well, we aim to be the patient-centered home for patients who struggle with overweight and obesity. So really great to be here.
Thanks so much, Brooke. Benoit, let's pass it over to you next.
Thanks so much for having me. So Benoit Bonsali, CEO of a company called Diverge Health. And the quick version of my background is started out in healthcare finance, went into social impact investing, spent 6 years in healthcare investing, and fell in love with investing in the Medicare, Medicaid services spaces, which is where I focus most of my time. Went to a nonprofit health plan Scan on the West Coast and led the diversified businesses umbrella of that organization, and then founded Diverge Health about 1.5 years ago with some colleagues and partners. And what Diverge Health does is we partner with primary care practices focused on serving the Medicaid population. We partner with plans to become the risk-bearing entity for those providers, low-income patients. And then we wrap those providers with very significant local infrastructure, so staff, technology, et cetera, to help us collectively succeed in that risk relationship.
Thanks, Benoit. And Sylvia, please round us out.
Hello, I'm Sylvia Hostin. I'm the CEO and founder of Greater Good Health and proud to be a Flair portfolio company. I have spent most of the last 2 decades in the depths of provider services in managed care based in Southern California. So I grew up in capitation and risk and delegation, worked at healthcare partners, DaVita Medical Group, and then ultimately, as you probably are aware, we were acquired by Optum. In 2021, I started Greater Good Health based on industry trends I saw and that Ian shared earlier this year, or earlier on this call, with the primary care physician shortage, growing senior population, obvious migration to value-based care. And I saw an opportunity with nurse practitioners specifically. So we at Greater Good Health work with risk-bearing organizations to help them build and run programs to achieve in their risk-based contracts. And we also take on risk ourselves with an alternative NP-centric senior-focused primary care model, which is probably more relevant for today's discussion.
Thanks, Sylvia. It is great to have the three of you here. Really fun to have the three of you together on one panel. So we want to jump right into it. And Brooke, let's come back to you first. We'll put the first question in Known Well's court. The topic of today's roundtable is around specialized primary care, but we shouldn't take specialized to mean low prevalence conditions, right? We know that over 1 in 3 US adults is affected by obesity. Tell us a little bit about the kind of the stigma that still exists around obesity in the US today. We know that it's there. How are you scaling a stigma-free primary care model at Known Well? And what types of opportunities does that create for the quality of care that you can deliver?
Absolutely. So to your point, we joke that our target population is 70% of the US that has overweight or obesity. So what's really interesting is it's your average patient, yet the primary care experience is extremely stigmatizing for that patient. It was an insight I had navigating getting myself to a primary care doctor every time I moved and reestablishing. And I was overwhelmed when I saw the research. Patients avoid primary care. They end up going to a lot because they have so many stigmatizing experiences and ultimately delay healthcare. So I think the unfortunate thing is while there's a lot of excitement around weight management, we've lost the forest for the trees a little bit. And step 1 is getting these patients back into healthcare. Step 2 is then how do we treat the obesity? So our focus is really building our experience ground up from patients. And honestly, it's the little things like patients can fit in our chairs. Our blood pressure cuffs always fit. We ask patients if they're comfortable being weighed. If they're not, our exam table can weigh them without them having the traumatizing experience stepping on the scale. And that even extends virtually in the sense of the language we use with patients and how we train our clinicians to be practicing in a weight inclusive way, which is a different way of practicing medicine. I would say the way we round out that primary care experience is understanding that for this population, they'll be more interested in metabolic health. So we offer the full suite of metabolic health services, including behavioral health, anti-obesity medications, nutrition, movement, all of that in the confines of the virtual and in-person clinic. So this was really about what would be the experience I would want in my ideal choosing a primary care clinic, and did a lot of focus groups and realized that a lot of these things we could do were frankly low-hanging fruit that I often joke shouldn't be a business. Like these should just exist everywhere. And that's how we're planning to scale it.
Awesome. We're so excited about the approach you're taking. And it's also fun that some of your early build is happening right in Flair's backyard in the Boston area. Great. Thanks, Brooke. Sylvia, let's go over to you next. We would be remiss to not really emphasize, as Ian started to at the start of the call, just the massive primary care physician shortage that we're facing in the US. On a brighter note, we do expect the NP kind of group to grow a lot in the US over the next decade, about 40%, in fact. Can you tell us a little bit more, expand on your introduction, the NP-led model that Greater Good is taking, and what is it about NPs that make them so well positioned to drive great primary care, and what are some of the early successes that you're seeing with the model at Greater Good?
Sure, yeah. First, from a regulatory perspective, many states have started to pass full practice authority laws to allow nurse practitioners to practice with full autonomy. So it's 28, maybe going on 29 states so far, and many more with plans to migrate. And to be clear, nurse practitioners, I think most folks on the line know, can assess, diagnose, code, document, and prescribe, much like their PCP physician peers can. With FPA, states have removed regulatory barriers that allow NPs to practice more independently without the constraints of working under a collaborative physician. Now, we can argue, and I will defend that I think physicians still need to be part of the care team. But what this does is, and by the way, this all was accelerated by the pandemic and the growing crisis. You mentioned the provider shortages. But what this does is I think it puts NPs in a unique position to lead around value-based care models. Throughout my career at HCP and even at Optum, we leaned on NPs heavily, tapping NPs to fill gaps where physicians were not able to, too busy, their panels were too large. NPs often would go into the home, take responsibility of high-risk patients, focus on chronic condition management, post-discharge care, take call, visit SNFs. They were flexible, adaptable, agile, and able to meet patients where they are. And I think the nursing training, I'm nursing trained myself, and I think the nursing training prepares nurse practitioners for a lot of the outcomes we hope to see in value-based care around care coordination, care planning, disease prevention, medication management, advanced care planning. And these outcomes have become more important and relevant in performance measures we're seeing in these new models. So for all those reasons, I think maybe the obvious thing is to really get behind nurse practitioners, and maybe the less obvious thing and what we're working on is building infrastructure around NPs, training and technology, a team, and workflows that really assist NPs to take on more of a lead role in primary care.
Thanks, Sylvia. And Benoit, we'll quickly move over to you here. Diverge Health team sound like the last mile delivery of great primary care to underserved patients in the communities where you're active. Can you tell us a little bit more about the relationship between Diverge, the primary care physician, the patient? Break it down for us. To what extent are your team's interactions with a patient directly informed by the PCP, or do you have the latitude to consider a patient holistically, design the right engagement model? Tell us how it works in practice.
Yeah, sure. Great question. So I think as we're even on this panel today, thinking about the different models that all of us are going to market, there are certainly pros and cons, right? Our model allows us to partner with a health plan, figure out the primarily independent primary care physicians and federally qualified health centers that are in their network already that might be a good fit for a partnership with Diverge. So that's like I'll call it a hunting license, right? We get a contracting structure in place, we get a set of in-scope practices, and then we've got a double sale in our model, right? We got to go to those practices cold, build a trusting relationship with them, make sure they know we're not hucksters, like we're there to not replace them, but enhance the care that they're providing to their patients. And then we contract with them too. So we've got contracts on both sides, and then that gives us a right to both support that primary care physician and their patients. Our chief medical officer says this really well. If we're doing a really good job, the patient has no idea who Diverge is. We are just extra staff that primary care physician now has access to see patients between visits, to support patients in ways both from a behavioral health perspective, from a social needs perspective, and even from a clinical perspective that they just can't do in the 5 to 10 minutes that they have with their patients. To your question on latitude, right? We are not a separate payer program. We are a PCP wrap business. And so our success is determined by our ability to engage with the practice, figure out their needs, figure out where we can support them, and keep that PCP as the quarterback. So I think there's a lot you can do in that model, right? But we forego a lot of control with wanting to empower existing stakeholders in a community to do their best work.
Nothing like a double contracting model in healthcare, but really exciting the impact that it unlocks. So we've talked a little bit about kind of care models that are specialized for certain populations. Sylvia, we would love to switch gears and get your take on models that are designed for certain geographies. And in a few minutes, we're going to hear from Dr. Richard Park. He built and scaled CityMD locations across urban neighborhoods in New York. Greater Good is focused on rural locations today. So can you tell us what were some of the important considerations so far in building that model?
Yeah, absolutely. And coincidentally, I'm in New York today and I'm sitting across from a CityMD building. Serendipitous. At Greater Good Health, we head into markets where there's a dire access issue, plainly put. We studied markets that are really struggling with PCP supply, maybe retiring physicians, communities where patient access is really a challenge. And in the markets we entered, patients are waiting far too long, months and months for a primary care appointment. These are senior patients, often at end of life, struggling with many chronic conditions. We also look at the NP patient ratio. Probably no coincidence that these markets tend to align with full practice authority legislation I described earlier. We're also looking at hospital systems, specialty network coverage, the Medicare market size, MA penetration, any available performance or MLR data is always helpful. But rural geographies are tough. To build an effective business model, we need to look at density, and we look at that first. As I've described, we partnered actually with a major senior health plan. That helped, of course, but we can't be successful and impact clinical outcomes without good patient engagement and strong talent. We've spent the last 3 years developing infrastructure and strategy to be employer of choice for nurse practitioners and other care team members, and investing differentially in learning and development around value-based care, clinical quality programs, recruiting, and culture. And we also wake up thinking about patient experience and marketing and community outreach. That's reflected in our clinics on stage, off stage layout when we designed it, our investment in a multi-purpose community room space, and our branding and messaging around building access and capacity in the community. So as we grow and take on more risk, I think we'll continue to look at how other technology and digital resources can help expand our network of providers and other tools to fill the gaps in rural markets, which I think will become necessary. But first things first, we just opened a couple months ago, so our focus has been brand, messaging, patient acquisition, and community outreach.
Awesome. And we'll pick up on that thread around risk contracting. And Benoit, jump back to you here. You're another great person to speak to this. And you came from the payer side of the industry before founding Diverge. So tell us with a little more specificity about the types of risk contracts that you're designing with Medicaid payers and how you expect those to evolve as you generate more data and even move across state lines.
Yeah, so we partner with plans in our first, say, 12 to 18 months. We have an upside only relationship, and then we transition to full risk from there for a following, say, 2 to 3 years. And that path is pretty standard, but how quickly you go down that path is really the variable that we see of companies that are like ours. And the particular complexity in the Medicaid population is we've got real heterogeneity in the population that we're managing, from moms and kids to disabled members and low-income adults for the states that have expanded Medicaid and everything in between. So that's a flavor of contracting. And I'd say what makes it difficult, what makes it difficult and what can make it a little bit easier to navigate is to go through a process whereby you're following the plan's lead on what they're comfortable not just signing up for, but actually administrating in the back end. And that's been key for us as we partnered with various nationals. Following their lead, like just as an aside, we had a long discussion about whether we could carve out certain populations from our risk pool. That ultimately didn't make sense for most plans that we're partnered with and needed to follow their lead and put other protections in place. So as an example.
Great. No, it's super helpful. And maybe just to give a preview here, we'll circle back to Brooke with another question, and then we'll wrap up with kind of a rapid fire round across the three of you guys. But Brooke, we mentioned the high obesity prevalence numbers a few minutes ago. What I found shocking in learning more about KnownWell is that there are only about 6,000 clinicians who are licensed by the American Board of Obesity Medicine today. So as you think about scaling KnownWell, how do you scale a clinically rigorous care model with such constraint on the supply of expert clinicians?
Absolutely. It's really two ways. First is we have really preferential access to those clinicians, given kind of the leadership on our team and their relationship with these organizations like the OMA. So that's helpful. Even if we hired all 6,000, we wouldn't get there for 150 million patients. Primary care is key. There are really two reasons PCPs in general don't practice obesity. One is they don't have enough education and time to do it. And two is they don't have the other resources in the clinic. They don't have the dietitian. They don't have the prior auth support for the medication. They don't have the behavioral health. And most PCPs want to do a good job. All PCPs want to do a good job in how they practice. So oftentimes they realize I don't have the tools. I'm just going to refer this to a weight center, which never has capacity. So we feel like we have a real preferential ability to fill those gaps for your average PCP through our own training and obesity, clinical decision support tools, more and different types of appointment types, and of course, the rest of the clinical infrastructure. As we've talked about here, there's certainly a shortage on the PCP side as well, but it is not as limited as the obesity side. So we think it's important that we upskill those clinicians.
Makes a lot of sense. Great. Okay, we are nearing the end of time here, so maybe we'll do 30-second answers each on this final question. We've learned a lot about your models at a high level, so let's get more tactical and narrow in on the end of this year. What's one exciting initiative or milestone that your teams are driving towards by the end of this year? And Benoit, let's start with you.
3 states. We're launching our model across 3 states, and we got to see good early metrics across both quality improvement and appropriate cost reduction across those 3 states. And then just good continued refinement, right? We're going to learn a lot. All these markets are different. How can we refine our model from there is another piece.
Perfect. Sylvia, over to you.
Oh, very similar. We just opened 3 primary care clinics in Montana, and we are like heads down focused on filling them, growing our NP panels, and preparing to take on more risk in 2025.
Awesome. And Brooke.
I wish I could give a different answer. We're opening in 2 more states, Texas and Minnesota this year. I would also say to founders on the call who might be interested in this conversation, we're unique in that we've raised our seed round and 3 months later started seeing patients like out of my house virtually. So we've been super scrappy in how we launched, and we're going into new states quickly. So if anyone has questions about trying to execute on that, the good and the bad, please feel free to reach out.
Thank you, 3. This was a great conversation. You always wish it was a little bit longer. Congrats on the progress so far, and we're excited to keep following along as your companies grow. I am going to now invite my teammate Ian back to the Zoom stage for a discussion with Dr. Richard Park.
Thank you so much, Tara, and really appreciate you for hosting the enlightening discussion. And Dr. Park, welcome. Thank you so much for joining us. Richard, maybe let me start off with a question. Throughout your career, you've been a physician, you've been an entrepreneur, now an investor. Maybe just share with our audience your journey. What got you started to go from being an ER physician to starting CityMD and really focus on solving the needs of a population in an urban setting?
Thank you, Ian. It's a pleasure to be here and for everyone's time. Really appreciate the invitation. It's an honor. Hey, just to double check, you can hear me okay?
Yes, we can hear you well.
Yeah. So listen, I'm an ER doctor. I spent about 10 years in the ER before 13, 15 years at CityMD. And a bunch of doctors punching above our weight class. And totally by chance, we were dragged along. There was no intent to be an entrepreneur, certainly no intent to be an investor. But if I may share a little bit, Ian, you and I share a common heritage. We were both, I guess, raised and lived in Queens, Flushing, Queens.
That's right.
And when I was growing up in Flushing, there were 2 large buildings called Skyline Towers. They were one on Cherry and Casino Avenue. They were 27 stories tall, sort of our tenement. And in between was a playground where there were about 30 Korean kids, purely statistically a complete anomaly, 30 kids, plus or minus 2 years of my age. And we all grew up there. And one by one, everyone left. And one of my recurring nightmares as a kid was on Casino. I'd see my mom and my brother and sister on the other side of the street, and I was left behind. I couldn't cross the street. That was a recurring nightmare I've had, and left behind and feeling abandoned. So surely all 30 kids, one by one, they open up a dry cleaner, they open up a store, a deli, or whatever back then, a 1-hour photo, a nail salon. And each of the families eventually move out. They buy a cape, and they move out to Long Island. That was the #1 goal of every Korean family. Buy a small home and move east. And so sure enough, I was the last family to leave. And so being left behind is a theme. One last story. I used to attend a church in Queens. It's actually in Long Island City, Elmhurst Woodside. And at its height, you'd have 3,000 immigrants attend. 22 years ago, I left. And 22 years later, I came back. I took my family, and we're attending this church now in Long Island City. And the people that were, I guess, 60 years old are now in their 80s. And they're hunched over, and they're still working, some of them. Most of them have passed, but some of them are still working. And if I recognized you, chances are life didn't turn out the way you had planned. Because no one plans to stay in Elmhurst or Long Island City. They all plan to go east to New Jersey now. And then the 8-year-olds, the kids that I recognize, now they're in their 30s. Like, they don't recognize, but I recognize them. If I recognized you, again, chances are life didn't turn out the way you had planned. Because they're in their 30s now, and I know who their parents were. I knew which parents were single, raised by single parents. I knew which moms were beaten by their dads, all the rumors and scuttlebugs. And fast forward 22 years later, you can see the scars, particularly the young women. Yeah.
And Richard, you talk a lot about the neighborhoods that you and I grew up, and I know many of the folks, especially in the building the startups and investing world, may or may not be familiar with some of the settings that, especially in the inner city, and of course, it impacts all ethnicity in many different ways. And you have started many of the successful care delivery organizations to serve those needs. Can you talk about some of the specific unmet needs in addition to what you share, and what were some of the care delivery models that you set up that were highly effective? Because we all know some of the highest performing risk-bearing medical groups are some of the Asian ones, and especially the ones that you have invested. So can you share with our audience why the focus model is such an important part of managing the cost of the population?
Yeah, absolutely. And so therefore, Ascend invests in vulnerable populations that were left behind. And that's our thesis. And as we work backwards, what does it take to help vulnerable populations that are left behind? They have specific special needs. And so one of our theses is how do we predictably, repeatably, scalably assist these vulnerable populations that are otherwise left behind? And so we made a very conscious decision, Ian, to get to your point, to serve, and all our LPs know, we serve the poor and elderly. And by and large, they're government-sponsored plans that are right smack in the middle of value-based care initiatives. And one of our earliest investments was a Chinese primary care group called Render, R-E-N-D-R, serves about 180,000 unique primary care patients in a single staff TIN model in about 100 locations in the 5 boroughs of New York City. We're not in the Bronx, but the 4 boroughs of New York City. And so you hyper specialize, and how do you use like what we talked about today, specialized primary care. I love the entire panel of everyone's doing this common theme, but we're all picking our niches, large niches, and breaking them down till they don't make sense and working on them to create consistency and efficiency.
And Richard, that's just given the sheer size, right? I think even coming from that background, like oftentimes we forget just how sizable of a population when you're becoming so focused could even get to. Can you also talk a little bit about what some of the engagement models that will be different? It has to be tailored and specifically designed for a very unique set of populations, and there are also some diversities across the subpopulations, right? So how do you think about that, and how do you achieve the kind of outcomes you have achieved?
Well, we continue to use Render as an example. So yeah, I do think it's actually the commonality. The playbook is the same. How you apply to a particular population might be a little different, but 90% of it is the same. 10% is what makes it customizable. And let's take practice A and B. This is how Ascend thinks of all of our portfolio practices, and as we think about investments. If you have 100 doctors separated at birth, identical twins, and the 100 doctors started practice A, and the second practice started practice B. Let's assume they both have an MLR, medical loss ratio, of 80%. But the way practice A got to 80% is They're all over the place. Some doctors are at 70, some doctors are 120, 130. They're scattered, completely entropic chaos. And it so happens that they average to 80%. Practice B, I tend to have long-winded answers. Practice B is at 80, but their standard deviation of practice behavior is from 70 to 90. It's very tight. And so in healthcare, we always hear that quality and efficiency equals consistency. This is how it works. So obviously, practice B had something external to it, work on it, called management, as a system that creates this narrow standardization. Practice B has a better management team. We invest in practice A because that's opportunity. When a man and a dog has an average of 3 legs, averages mean nothing. And that's all of human behavior, especially physician groups. When you have averages and you see the standard deviations and they're so far wide apart, that's called opportunity. If you can get the management team from team B to come in and work on team A, there's opportunity. So specifically, that applies to every practice, whether yellow, green, blue, it doesn't matter. But there is some specificity. Now, to Render in particular, they were in certain ways born on third base and thought we hit a triple, right? What do I mean by that? Their natural admissions per thousand are much lower than the general population for a host of reasons. But our admissions per thousand are lower than others. Okay? And therefore, if you want to save on cost, you have to really focus on your ambulatory. So to do all that, you'd be surprised in a lot of these ethnic markets. If you were to send an Excel file, most of them can't open it because they've not upgraded Windows 7 to 11. So really basic things like that, you have to bespoke by group.
That's a fascinating. And Sean, in the prior discussion, one thing he didn't mention about it was a previous technology stack, which makes sure all the physicians are on the same EMR. So that standardization is such an important piece. And maybe speaking of which, Richard,
Ian, if I could just, can I just talk to that too a little bit? I know people talk technology. I'm a big believer. Actually, I'm not a very big believer in technology. I don't know enough about that, but we're a mud wrestling group of operators. And so I do know technology is important. Render, as an example, about 90% of the physicians were on an EMR platform called MDLand. MDLand is the EMR, for some reason, mainland Chinese doctors here. Now, you would think that's a huge advantage. It would have been, except they've all used it differently for 20 years. And there were 15,000 spellings for pairs. And so our data, there was no data governance. And so everyone's spelling things differently. None of your data is accurate. They aspire to be value-based care providers taking on risk when they have Windows 95. Can't tell you how many patients they've seen that day with dual eligible United. And so I would say, I know people are focusing on the ceiling, something sexy with ChatGPT and AI. That's all the rage now. I get it. Don't forget the flooring. The flooring. Having people use email, paying for Microsoft Office, can open your Excel file so we can all decide to spell, or we call it data governance. Spelling is half the battle here. Okay, so workflow management is really important, especially in these provider groups.
Totally. And this is something, Richard, I think you and I traded like war stories when I was still an operator. Of course, you're still running practices, and just the importance of even just doing the table stake, the basics. Maybe we have about a couple of minutes left, and maybe following the technology thread, not to be remiss, but we are technology investors just like you guys are. Like, are there areas where you see in the near future that some of these newer technologies can greatly improve the efficiency and eliminate that long tail you just shared?
And so listen, whether healthcare 18, 20%, health is wealth, maybe 20% of healthcare GDP is not enough. Maybe we should be spending more. I don't know the answer to that. I do know what we get for that money is not good enough, right? So if we spend the money, we better get our money's worth. And so I do think technology can help us get better productivity and efficiency. So assuming you've invested in the basics and that everyone uses email and have upgraded their computers and is compliant, and and that they could use your technology. It's a big assumption, right? You got to make sure that efficiency. And so if our primary care doctors today can have a panel of 1,500 or 1,200, 1,000, maybe through technology, they'll get to 5,000. And so we do believe in technology as making us more efficient so we can do a better good. At Ascend, one of the early conversations I had with Insan, my co-founder, is, do we foresee a world of Neiman Marcuses? Because there's a need for that. Or do we prefer a healthcare world of Targets? Good enough, really great, or Costco's a great example. Do we see a healthcare world of Costco's?
Yeah.
Better good for more people.
100%. And Richard, I just want to thank you and appreciate you for sharing the insights. And let me close off this webinar and as our speakers, and thank you, Dr. Park, for joining us. We cover a lot of grounds, but obviously there are still a lot to talk about. So as always, please reach out to us if you would like to continue the conversation. We look forward to seeing you all for our next expert roundtable. Thank you so much for joining us.